Okay. Good morning, everyone. My name is Acton. I use he, him pronouns.
And I'm Mitchell. I also use he, him pronouns.
We are two third-year family medicine residents at Swedish First Hill, and we appreciate everyone showing up for our Grand Rounds presentation on stimulant use disorder. So what we're going to be covering today, we're going to be talking about some of the populations who use stimulants on both a national and local level. We're going to talk a little bit about the pharmacology of stimulants. We're going to talk about how to diagnose stimulant use disorders in patients, explore some of the health effects that we can see with stimulant use and stimulant use disorder, and then at the end, discuss some evidence-based as well as off-label, both behavioral and pharmacotherapeutic options for treating folks with stimulant use disorders. And before we get started too, I apologize for not mentioning this in the beginning. Feel free to throw questions into the chat. However, we're going to be holding our Q&A until the end of the presentation. So before we take a deep dive into how stimulants affect folks on both the pharmacologic, physical health, mental illness, as well as how to treat, we wanted to take a dive on who's being affected by stimulant use disorder. Because at the end of the day, it's our patients and communities that take precedence. So in looking on a national level, for methamphetamine in particular, CDC data between 2015 and 2019 showed that there are 1.6 million adults in the US who reported past year methamphetamine use. Of those 1.6 million, around 50% were diagnosed with a use disorder, and around a quarter of them were reporting that they're injecting methamphetamine. When looking at cocaine, SAMHSA examined between 2002 and 2019, and it overall showed that there is actually a decrease in folks with cocaine use disorder from 1.5 million in 2002 to 1 million in 2019. This is just a graph that's showing that SAMHSA data I was talking about earlier. So as you can see, there's an overall trend in decrease of a cocaine use disorder. The group, the age demographic with the most prevalence was that 18 to 25. Now, interesting, another thing that we're looking at is not just stimulants as a primary substance or drug of choice, but also its increasing prevalence as a secondary, tertiary, or just another drug for folks with addiction and substance use disorders. So this is a really, this graph represents a large a survey that was done for folks entering treatment facilities who reported stimulant use in addition to another drug of choice. And again, it's representing this increasing prevalence that we're seeing as a whole. So from 2011, around 19% of folks reported stimulant use with another substance, and that increased in 2017 all the way up to 34%. This trend has continued to elevate. I'd be curious to see what it is today in these last 3 years. Now, in addition to more folks using stimulants, one of the really concerning things is there's been a disproportionate increase in the amount of overdose deaths. And so CDC between 2009 and 2019 showed that the overdose rate had increased 10 times from around 0.5 folks per 100,000 in 2009 to 5 in 2019. We've seen that this is increasing in both psychostimulant use with opioids and without. And when I'm referring to opioids, that does not include synthetic opiates, fentanyl, for example. This is just a slide that represents that data talked about in the previous screen. As you can see, there's an overall increase in trend, most sharply occurring these last 5 years. Now, like many things in medicine and society as a whole, there's been a disproportionate impact on marginalized communities. The CDC and SAMHSA data reported, trends we're seeing across the populations on a national level as a whole. And then this is a really recent study published in JAMA Psychiatry in September of this year that did a bit more of a deep dive into some more specific communities and subgroups that were being impacted by overdose deaths and risky use as a whole. So this was a really large cross-sectional analysis. I looked at almost 200,000 patients between 2015 and 2019 on methamphetamine use specifically. Again, it showed an overall increase in prevalence of use from 1.4 to 2 million people. It showed this disproportionate rate in overdose deaths and 183% increase. And there's an overall increase in use and deaths across all demographics, but there's a disproportionate increase in cis gay men and women, as well as Black individuals. And then we're looking at adjusted prevalence across certain subgroups as a whole. There is a higher prevalence in LGBT plus communities, rural communities, American Indian, Alaska Native, Native Hawaiian, other Pacific Islanders, and then white communities. The caveat with that white communities is that specifically, they're specifically talking about more rural white and not urban and suburban. And so again, this is really highlighting the importance of resource redistribution when we're thinking about substance use disorders and stimulant use disorders. The study was making an argument as a whole that so much attention has really been given to the opioid use epidemic, and understandably so. And a lot of that was when medicine society started to see the impacts it was having on more white affluent communities. And while resources, attention were being devoted to this, there was a rising epidemic occurring with methamphetamine use and stimulant use in communities, but it was again disproportionately impacting more marginalized communities and was not getting the due attention that it deserved. So now we're going to move into talking about what are we seeing with stimulant use in Washington State and King County specifically. So this is some of the data that we could find was talking about admissions by primary drug across the state. It's showing relatively stable trends. If you go to the next slide, this is the same data just represented as a percentage of drug of choice for state for admissions into the hospital. You can see that methamphetamine has remained fairly consistent, around 17% as of 2015. Cocaine remained around 2%. I'd be curious to see what this data showed between 2015 and 2020, because that's when we've really been seeing a rise in stimulant use. And again, this is by primary drug and not showing, secondary, tertiary, or, stimulants being just another drug that someone chooses to use. And so I think the prevalence is probably even higher than that. So this is some more recent data that shows overdose deaths involving stimulants in Washington State. Again, it mirrors a lot of the trends we're seeing on a national level. So the figure on the left is a hot map showing deaths involving methamphetamine per 100,000 residents between 2003 and 2004. The state average was 1.5. The figure on the right represents between 2019 and 2020, and you can see it increased from 1.5 to 9.5 per 100,000 residents. When specifically looking at King County, so in 2003, 2004, that number per 100,000 residents was approximately 1. It increased to 8.6 in 2019 to 2020, which showed an increase in almost 708%. So what are the big takeaways in this overall? There's been an increase in use and use disorders involving stimulants, primarily methamphetamine, both on a national, state, and local level. While there's been this increase in use, there's also been a disproportionate increase in the number of overdoses. And unfortunately, like many things in society and medicine as a whole, there's been a disproportionate increase in the prevalence in deaths within certain marginalized communities.
So then we're going to take a moment here to review pharmacology and pharmacokinetics. So reviewing the similarities and differences of cocaine and methamphetamine. Remembering that cocaine is derived from leaves, specifically the coca plant, whereas methamphetamine is synthesized in a laboratory. The duration of time for the effect of each drug is also very different, with cocaine being much faster onset with a shorter half-life and shorter duration, where methamphetamine can last a little bit longer. Mechanism of action, specifically highlighting some of this as it'll be more interesting later on with treatment. cocaine primarily interacting with the reuptake transporters for both dopamine and norepinephrine, and also working as an inverse agonist, reversing the direction of the transporter, where similarly, methamphetamine also binds to reuptake transporters for catecholamines. It also enters the neuron and helps to fill more vesicles with newly formed catecholamines to then move into the synaptic cleft. So here's a diagram here showing methamphetamine, specifically showing the multiple different activities here with binding on receptor sites, formation of vesicles, and increase of catecholamines in the synaptic cleft. One of the big pieces of the pharmacology is some of the toxicity, especially in the brain that we see on a human level. And some of those things I just want to briefly go through here. So methamphetamine, the way that it interacts with some of these receptors and the increased amount of catecholamines modulates these different cascades, which result in neurotoxic and cytotoxic effects, as well as oxidative stress and neuroinflammation. And we see this increased exposure associated with neurotoxicity and worsening psychiatric and behavioral issues down the road in chronic use. And then also looking at a diagram here of cocaine, similarly looking at the dopamine reuptake transporter in the synaptic cleft with increased dopamine in the presence of cocaine. The reason I keep bringing up dopamine of all the catecholamines that we're talking about is reward and reinforcement and what we know about the impact that dopamine has on the brain as a pleasure chemical and how it is linked with reward reinforcement as well as addiction. And so a lot of what we're going to talk about down the road here in terms of treatment options later in the talk will focus a lot on catecholamines, especially dopamine.
So now that we've talked a little bit about who's being impacted by stimulant use and the pharmacology behind it, we're going to transition into diagnosis, some common health effects that you can see with stimulant use and substance use as a whole, and then ultimately treatment. So first we're going to start with the diagnosis. So like other substance use disorders, you're using DSM-V criteria. I won't belabor you by reading points 1 through 11. But I think the big question is, why do we care of identifying a use disorder versus just risky use or use in general? And the reason is because if someone is diagnosed with a use disorder, they are more likely to have certain comorbidities, and that risk of having those comorbidities increases based on the severity of the use disorder. So big takeaway, if someone is having using stimulants or using any substance in general, you should screen them for a use disorder. If they meet 2 to 3 of these criteria, they're diagnosed with a mild use disorder, moderate 4 to 5, and then severe 6 or more. So now we're going to look at health effects of stimulant use. So first, we're going to start with some of the acute signs you're going to see. I'm not going to go into detail of all of these, but the big takeaway is, treat these acute symptoms, manage withdrawal, think blue plates, mitigate risk. Some of the long-term management when treating stimulant use disorders actually does focus on the withdrawal, which I'll let Mitchell talk about a little bit later. But the big thing is, if someone has acute use of stimulants, you may see tachycardia, hypertension, hyperactivity, a decreased appetite, insomnia, anxiety, certain movement disorders, which I'll talk about, agitation and psychosis. Withdrawal, you're going to see the opposite of that. Anhedonia, irritability, poor concentration, and excess in appetite. Usually you see hypersomnia, you can also see insomnia, and then usually you see psychomotor slowing, but you can see a paradoxical agitation. Okay, so now I'm going to shift the focus to less of the acute signs of stimulant use and health effects with that, and more so what you see with continued use, chronic use. This is a schematic that I've kind of adopted for this talk that I've seen used elsewhere that helps me think about how to approach substance use disorders. I jokingly say this is like one of the few pyramid schemes I buy into. Basically what you're looking at here is it's kind of the approach that you take to thinking about it. So you start at the bottom and work your way up. So like many things in medicine and society as a whole, there are larger isms that lead to inequitable care and outcomes, so race, sexual orientation, class, employment, etc. That, any one of those could be a presentation on themselves. So for timing's sake, we're going to be focusing on the top 3. So social context of use, anytime we're thinking about a substance, whether that is a stimulant or any other substance, there are certain social determinants and spillover effects that drug use can have on our patients. So we're starting there. So one of the big social determinants are what are the interactions people with substance use disorders are having with healthcare. And I'll take a minute to pause here. I should have prefaced, when I'm talking about these social determinants, as well as the routes of administration, we're really going to be focusing on substance use disorders as a whole. And then for that last point, when we get into the substances themselves, that's when I'm going to be talking about some of the specific things you can look out for with stimulant use. So interactions with healthcare. It's been well known that folks with substance use disorders are more likely to be discharged against medical advice or prematurely. I would caution everyone to, we know that, folks who are discharged, quote unquote, AMA have worse health outcomes. There's an increased 30-day mortality and risk of hospital readmission. It represents a missed opportunity for us as healthcare providers in a system to engage with people struggling with addiction. And words matter. Be careful and cautious when you're documenting to not put AMA repetitively. That does increase the risk that someone's going to encounter bias within the healthcare system. This was a study that interviewed folks who had been discharged prematurely on what were their reasons for leaving. The paper identified 4 big points that pretty much every single patient identified, and that was undertreated withdrawal and ongoing cravings, minimized and uncontrolled acute and chronic pain, perceived stigma and discrimination by hospital staff about their substance use disorder in particular. And then this last point was something I wanted to highlight was triggering thoughts of past experiences with incarceration. And, it's something whether they have an addiction or they have encountered the criminal justice system to think about, how stressing and traumatizing folks being in the hospital can be. Some other social determinants of health to think about for folks who struggle with addiction are the effects that drugs can have on motivation and cognition. Hygiene is a really important one. I'm going to take a step here to talk a little bit about dental and particular stimulant use. One common thing that I hear thrown around is, quote unquote, meth mouth. Now, this is not a representation of methamphetamine itself on dentition, but more so some of the spillover effects that come with that change in cognition and motivation that can come with stimulant use. The biggest predictor of poor dentition in someone with a methamphetamine use disorder is the length of use. And really the largest impact that you can make is simply giving someone a toothbrush. There's also been shown that folks with methamphetamine use disorders have a much higher rate of sugary beverage consumption. There's been a study that showed that folks with a methamphetamine use disorder drank around 2 to 3 sugary beverages a day, whereas a similar cohort was 0.3. Those effects on motivation cognition can lead to poor wound care. There can be decreased interactions with healthcare for some of those quote unquote AMA factors we talked about earlier, as well as in an outpatient setting, patients having an increased risk of being marked as no-showed for showing up late to an appointment. Malnutrition is another huge thing that impacts folks with addiction. There's multiple reasons for this, some being financial resources that are devoted to use and subsequently difficulty affording food. Lack of appetite is huge, particularly in stimulant use disorders. And then when folks are getting admitted to the hospital, there is risk of repeating syndrome. Infectious disease and some of the spillovers are another really important thing to think about with addiction. So I think a lot of us are aware of the importance of safe needle practices and safe injection practices. We have so many wonderful folks in the King County area with needle exchanges that I really encourage everyone to take some time, if you can, to go talk with them so that you can get more up-to-date harm reduction counseling with your patients. This could fit under multiple points, but the housing instability for infectious disease, right, that could go under malnutrition from those financial resources that are being devoted to use. But when thinking about the infectious disease side of things, there can be an increased risk of TB. Folks are more likely to be staying on the streets or in shelters. And then a last point is the increased risk of STIs. So one thing I wanted to highlight was this term chemsex. If you aren't aware of that, it is essentially using substances to enhance the pleasure of sex. And sometimes it comes to a point where folks are actually dependent on substances to engage in intercourse. Stimulants, methamphetamine in particular, are incredibly common. Another one that you'll see is folks who participate in anal receptive intercourse, may be talking about nitrous oxide use or poppers. Nail polish is another common term for that. And then alcohol is another one. Why this matters is that impairment in cognition can lead to inconsistent barrier protection and lead to a higher risk of exploitation. Lastly, sorry if you could go back on that. Lastly, violence and traumatic injury. I want to be super, super clear that substances themselves do not cause violence. And really, this is a representation of super complex interactions and situations which lead to a higher incidence of violence. And the reality is that there's a higher likelihood that substances are involved. And so folks who have addiction, who have substance use disorders, there's a higher incidence of PTSD, higher likelihood that they're going to be involved in some form of trauma. And so keeping that in mind when you are encountering them, treating them, counseling them. So now we've talked about some of the social determinants that can affect folks with addiction. We're going to talk about how substances can be used. Similar to like a real estate, location, like the route of how someone is using a substance is really important when thinking about the health effects. So again, this isn't necessarily talking about stimulants in particular, but substance use as a whole. So think about insufflation or snorting. Really common things you can keep on your radar are the tissue damage that comes from that. With inhalation or smoking, pulmonary effects, pulmonary hemorrhage, some of the chronic toxicity that you can see, barotrauma. When folks are injection, whether that's intravenously or muscling, increased risk of infection, vein sclerosis, and then this last one, talc granulomatosis. Talc is a stabilizer that's used in multiple tablets, and it's actually a bulking agent that's sometimes used to cut cocaine. Those filler particles, they can get entrapped within capillary beds when folks are injecting, and this then causes a foreign body reaction with a granuloma, and a fibrosis can occur. Really common, it can occur anywhere, but some of the more common spots you'll see it are in the lungs and the eyes. And then a last route that people sometimes do is rectal administration, also called booty bumping or boofing. You can see direct tissue damage, edema, and then a chemical proctocolitis. Now, in thinking about stimulants and specifically, there is varying bioavailability based on the route of administration. So cocaine, when used intranasally, has about an 80% availability. When smoked, around 57, 60%. And that's super variable depending on the skill level of the individual operating the pipe. Methamphetamine, on the other hand, when smoked or used intranasally or orally, is around 67% available, whereas if it's injected, it is 100% bioavailability. Okay, so we've talked, big picture for substance use disorders in general, for social context, how they are being administered, and now we're going to dive into the substance itself. So this is where we are going to talk a little more specifically about stimulants. So I'm going to break this down kind of by organ system. So we'll start with pulmonary. I will also preface that this is an incredibly broad topic. This is kind of going to be a 30,000-foot overview. I might do some partial deepish dives on certain conditions, but it's not going to be all-encompassing. So starting with pulmonary, a really common one to think about is crack cocaine and some of the health effects that you can see with this. Folks who do smoke cocaine, there's been some studies that have shown, 90+% of them are going to endorse some type of pulmonary or respiratory complaint within 30 days of use. This is usually like kind of a chronic respiratory complaint, but it can develop into an acute situation rapidly. And I'm going to talk about that at the end with that hypersensitivity pneumonitis. But common things you can see for folks who are smoking cocaine is this pigment deposition. That's from the carbon pigments in the combustion of the crack cocaine. You can see barotrauma. This is due to the intentional cough or valsalva that some folks do to try and increase the high. So you might see a pneumothorax, a pneumomediastinum. There's chronic toxicity. You can see a fibrosis similar to like that talc granulomatosis that we were similar or caused by that talc granulomatosis I was talking about earlier with smooth muscle hypertrophy. You can see foreign body granulomatosis, pulmonary fibrosis, and then finally that I'll bring a little bit of attention to is this hypersensitivity pneumonitis and interstitial fibrosis. You may have heard this called crack lung. So this is something that usually develops within 48 hours. It's a pretty acute onset, and the big risk is this progression to respiratory failure. It's a syndrome that's characterized by respiratory distress with fever, hypoxemia, and hemoptysis. When someone's getting worked up for this, you may see ground glass opacities on chest x-ray, and if they got a lavage, it would show an elevated eosinophil. Treatment for this is supportive therapy. On the cardiovascular side of things, multiple effects that you can see with stimulant use in the acute setting, hypertension, arrhythmias with sinus tach, SVTs, other ventricular dysrhythmias being the most common, myocardial infarction. So this is when specifically looking at cocaine, the risk increase within 24 hours of use. It can happen in the absence of coronary artery disease. And the pathophysiology behind this is that vasoconstriction and dissection of the coronary arteries that you can see with stimulant use, as well as some of those pulmonary effects and the increased right heart strain that we talked about in the previous slide. Another really common cardiac comorbidity that you can see is cardiomyopathy. Typically, this is going to be a dilated cardiomyopathy with reduced ejection fraction, most common and higher risk with meth. When it is a mild or moderate level of disease, so think New York class 1 and 2, it is possible to reverse the physical effects with cessation. Otherwise, if they're a severe cardiomyopathy, it's unlikely that cessation is going to lead to that. And so you're going to need to treat, with standard therapy in addition to treating the use disorder itself. The pathophysiology behind this is, there's a lot of reactive O2 species, excess catecholamine, vasospasm, ischemia, and oxidative phosphorylation that leads to these structural changes in the heart. You can also see a stress cardiomyopathy. Aortic dissection, another common, I shouldn't say common, but extremely rare, something that should be on our radar. Stimulant use is the second leading cause behind hypertension. And finally, intracardiac thrombi. There was a small study that reported up to 30% of folks using methamphetamine had these. On a neurologic level, seizure, particularly with cocaine use, is something you can see. How this works is cocaine, one of its main metabolites. I apologize, I'm probably going to butcher the pronunciation of this, but benzoyl-ecgonine, or BZG for short. It has a half-life of around 7.5 hours, and this is the main one that's been identified, which lowers the seizure threshold and increases that risk. And so big thing to keep in mind with this is if someone uses cocaine, the risk for seizure can last hours or even days after use. There's an increased risk of stroke, a higher prevalence for whatever reason. I couldn't identify or find why of hemorrhagic stroke in younger individuals. Otherwise, you're going to be seeing ischemic stroke, and that's due to the vasoconstriction, thromboembolism, and vasculitis that you can see. Finally, in both an acute as well as chronic use, you can see motor impairments, myoclonus, tics, bruxism, transient chorea being most common. And finally, there's some debate on cognitive impairments with chronic use. And there's overall mixed data, but what gets argued is that you can see impaired executive function, episodic memory, and information processing. The idea behind it being some of those neurotoxic effects that Mitchell talked about earlier. So now this is going to be another part where before diving into stimulants specifically, I'm going to talk about addiction and substance use disorders as a whole because it's so common, and that's with psychologic disease. So in general, if you are meeting someone who has a substance use disorder, always have a high suspicion for some type of psychiatric disease. Around 45% of folks with a substance use disorder are going to have a psychiatric disease. Depression, anxiety, PTSD are the most common. The likelihood of having some sort of mental illness increases with the severity of the substance use disorder. And then the vice versa holds true as well. If you're meeting someone with mental illness, there's a higher likelihood that they're going to have a substance use disorder. 1/5 of folks with some type of psychiatric disease are going to have a substance use disorder. And so think about screening for substance use if you meet someone who has depression, anxiety, etc. History is key, particularly when trying to differentiate from a substance-induced psychiatric disorder versus a primary psychiatric disorder. In the outpatient setting, use validated screenings. I listed a few there. Keep a high suspicion for trauma, remembering that the substances themselves do not cause violence or trauma, but there is an increased likelihood that someone will have experienced it if they do have a substance use disorder. Family history, past treatments, whether good or bad. And this should be a standard practice across all of medicine, not just with substance use disorders, but keep harm reduction counseling in mind. So when specifically looking at substance use disorder, there's a lot of research out there. Methamphetamine use in particular has been shown to have high rates of multiple comorbid psychiatric disorders. You can see anything from psychotic disorder, primary mood disorders, anxiety, ADHD. One of the more common ones is depression. And the idea, or some of the argument that gets made with this, is that folks are actually self-medicating with the stimulants to treat some of their depression. We talked a little bit about this psychosis that can occur with acute use, but the one I wanted to highlight was this methamphetamine-induced psychotic disorder. What this is psychosis that mirrors a paranoid schizophrenia that can persist in the absence of use. It's debated and has an unclear pathophysiology. The underlying thought is that it's multiple factors that contribute to it, with a stress vulnerability model suspected. So how I kind of think of that is, like the ACE model that we see with pediatric and adult health outcomes. There's been neuroimaging studies that do demonstrate chronic methamphetamine use, changing the structure of the brain, both with those serotonergic systems, glucose metabolism, and the gross structural anatomy. There's that neurotoxicity effect that we have talked about already. And then there's also being studies done on certain genetics and biomarkers that might increase the risk of someone developing this disorder. It can affect anywhere from 1/4 to half of people with methamphetamine dependence. Have a high risk or high suspicion of this developing between 1.5 and 5 years of use. The symptoms are going to amplify over time. It's going to mirror this paranoid schizophrenia. It's usually positive symptoms. And there's no standard of treatment, but treatment with antipsychotics is, what is most commonly done to relieve some of those really stress-inducing psychoses that are affecting our patients with methamphetamine use. Haloperidol and olanzapine have been the most studied and have been shown to have some benefit. But the big thing is cessation is key. Mitigate those distressing psychosis symptoms. And then once someone's in a more stable state, really focus on treating anxiety and depression, because that's been shown to be the major trigger for someone going back to use. Finally, I touched on this a little bit already under the social determinants, but when looking at kind of the head, ears, nose, throat, dental health is a huge component. And then there's the nasal and palate injury that you can see due to the vasoconstriction and tissue necrosis. Okay, so that was a lot of information. Again, big takeaways from this. Recognize the acute signs of toxicity withdrawal. Think blue plate medications. Treat as able. once someone is stabilized, history and exam is key to guiding further workup. Like any other disease we have in medicine, recognize that there's multiple facets beyond just the substance itself that affects our patients' well-being who have a stimulant use disorder or addiction in general. Again, this is something that should permeate all of medicine, but take a harm reduction approach when able. And anytime you encounter someone with a stimulant use or substance use disorder, have a high suspicion for co-occurring psychiatric disease.
So we want to take an opportunity to talk about various different treatment modalities that have been researched and kind of do a survey of options that are available and the evidence behind them. So starting with behavioral interventions, which should be a part of any treatment plan for people with substance use disorders, and specifically with stimulant use disorders, contingency management has shown the best evidence for benefit. Other types of therapy that have been reviewed with some evidence but less than contingency management include cognitive behavioral therapy or CBT, community reinforcement approach, CRA, and then something that should be included in any interaction and treatment of people in general, motivational interviewing. So just talking a little bit more about contingency management, as I feel it's probably pretty underutilized and underdiscussed, especially when we were discussing this topic. So contingency management, so thinking about the reinforcement and reward pathways. So this specifically works with positive reinforcement for desired behaviors. So an example of that would be a negative urine methamphetamine result would end up with the patient getting a voucher or some kind of reward for that behavior. And what we've seen with contingency management is beneficial impacts on many different aspects of the individual's care, whether that's engagement in treatment, reduction in higher risk sexual behaviors, mood and affect, abstinence, craving, and their overall well-being. So we'll start with methamphetamine use disorder. So this is a slide just kind of showing a survey of many of the different medication groups and specific medications that have been studied before, as well as some of the evidence, as well as other issues with some of the studies. So these are some that are highlighted from the last slide here of things that have been studied without much benefit. And so we won't focus on any of these today. And some of the medications that we will review that may show some evidence and may be more helpful include some that we'll review here that I put on this list. So first, we're going to talk about the mechanism of a few different medications that were studied pretty recently. The first one is Bupropion, which we know works on norepinephrine and dopamine pathways. We think that it can help reduce some of these negative symptoms that Acton was discussing earlier, especially with withdrawal and the dysphoria after use of methamphetamine, which may help kind of break that cycle of reuse and help reduce use. And then Naltrexone, which is an opioid receptor antagonist that we commonly use for alcohol use disorder and sometimes used for opioid use disorder, is thought to reduce this reward pathway, as we discussed earlier with dopamine, that's associated with desire and cravings. So at the start of this year in the New England Journal of Medicine, they did a study combining both Bupropion XL in the 450 milligram daily, as well as the Naltrexone injectable that was every 3 weeks. This was a study that had 403 people in it, specifically with moderate or severe methamphetamine use disorder. Just highlighting the specifics of this trial, so it was a multi-site, double-blind, 2-stage, placebo-controlled trial that used a sequential parallel comparison design. And so just kind of a brief thing on that. So after stage 1, when they had separated out the trial group and the placebo, they then took the placebo group that didn't have any response on their own with the placebo and recycled it through and randomized it 1-to-1 between the treatment arm with Naltrexone and Bupropion and the placebo. So there was a 2-step opportunity here for evaluation. So the primary outcome that the authors were looking at was at least 3 negative urine tests for methamphetamine out of 4 at either the end of stage 1 or the end of stage 2. And then the secondary outcomes, which are always helpful to look at too, is the percentage of methamphetamine negative urine samples in general, as well as cravings, depression, and the treatment effective assessment. So here are some of the results. So after stage 1, it did show that in the treatment group for 3 out of 4 negative urine samples, there was 16.5% in negative tests compared to 3.4% in the placebo group. And then on the right side here, so looking at after stage 2, the treatment group had 11.4% response with this at least 3 out of 4 methamphetamine negative urine samples compared to 1.8 in the placebo group. So the chart on the left here just kind of showing the difference in the weighted average in the stages between the trial arms, as well as the negative urine tests over time here on the right. So the next one that I wanted to review is Mirtazapine. As we alluded to in our title, this is one I think that most of us have heard or have used, at least in our program here. So this one acts as a mixed monoamine agonist-antagonist. So what that does is facilitate some of these catecholamines that I discussed earlier, specifically with the dopamine, serotonin, in the areas of the brain like the mesocortical limbic area, which we know are implicated in reward, craving, and seeking. That is very linked with the patterns of substance use and reuse. And so with this increased prevalence of the monoamines, we think that some of the benefits of the Mirtazapine may help with the withdrawal and cravings, which may help improve abstinence and reduce use. So just briefly going through a little bit of a trial that was done in 2019 in JAMA Psychiatry. So this was looking at a couple different measures here. It was a small sample size with an N of 120. So looking at folks with methamphetamine use disorder and also trying to evaluate reduction in sexual risk behaviors. So they looked at a specific subgroup here, specifically cisgender men, and transgender women who were having sex with cisgender men and that had methamphetamine use disorder that was active. And this specific trial noted that they were also utilizing CBT and MI. So in this trial, they used 30 milligrams of Mirtazapine with a primary outcome that they were trying to evaluate was positive urine tests for methamphetamine over weekly intervals, while also trying to assess secondary risk behaviors. Just like with some of the things that Acton also noted earlier, the sleep, cravings, depression, and severity dependence are very important in understanding the complexity of these patients. So this is also evaluated post hoc in this trial. Some of the results here, so with a lot of these medications, suboptimal adherence was observed, but some notes here. So there was a statistically significant decrease in the methamphetamine positive urine results, and there was also a decrease in some, but not all, high-risk sexual behaviors. And then another medication I wanted to highlight here was methylphenidate. What this does is binds to dopamine transporters and norepinephrine transporters and helps to increase the exposure in the synaptic cleft and post and the neuron to dopamine and norepinephrine at the cleft and prevents some of that reuptake. So there's a study in 2014 published in the Addiction magazine evaluating extended release methylphenidate as a treatment option. Again, a very small sample size of 110. They did a double blind for 10 weeks, followed by 4 weeks of a single blind placebo. Here's the kind of dosing increase that they did here after each week, and then getting up to the 54 milligrams for the majority of the trial. They also used a mixture of motivational interviewing, contingency management, and CBT. The outcome that they were looking at was days of self-reported methamphetamine use for the last 30 days of the 10-week trial. And then for secondary outcomes, looking at self-reported reduction in use, and then methamphetamine use with results from the urine drug screening, as well as retention and craving. And what the results showed was there was not for the primary outcome, there was not statistically significant evidence to support that kind of like 30 days at the end. But it did show that folks that had previously used a lot more at baseline were more likely to have reported fewer use days over the active trial period. So this is just kind of some graphs showing those. So on the left, the change between the placebo and the trial group. And then on the right, looking at the baselines compared between the two different groups and the impact of methylphenidate. So kind of summarizing some of the more recent studies, there aren't any current approved treatment options for methamphetamine use disorder, and there's been some studies, as I alluded to earlier, but what we know so far, and it is not kind of in concrete yet, but we see some possible promise with the combination of the Bupropion and the Naltrexone injectable, but small sample size, it would really benefit from further investigation. Mirtazapine and methylphenidate may help reduce use in some subpopulations. And then thinking about bupropion monotherapy for folks with less severe methamphetamine use disorder that may have comorbid depression. And highlighting that any treatment plan should include contingency management, which has the best evidence. And then taking a moment here to go through some of the previously studied and more recent evaluations of evidence for pharmacotherapy for cocaine use disorder. So similar to what I did before. So this is a lot of medications that have been tried over the past, and then evidence of benefit and the strength of evidence. So some, just highlighting some of the ones from that list that have been studied that did not show much benefit that we won't really focus on today, and instead kind of shifting into some of the more recent ones, and I'll highlight some of these medications that may show some promise. So the first one, Modafinil. So again, kind of getting on this mild stimulant pathway. So again, getting dopamine neurotransmission, and there's also some glutamate neurotransmission here. There's some thought that folks that have been using cocaine chronically have glutamate abnormalities in terms of depletion. So thinking about thinking about assessing and addressing that glutamate depletion with modafinil. And so a bunch of different studies have been done on this, a lot of them based on early human lab studies that showed that there was some euphoric effect blocked when modafinil was pre-used before cocaine. The clinical trials based on these early postulations only had mixed results and not a lot showing reduction in cravings or use. And then a lot of the outcomes, especially during some of these studies that are reviewed, were likely impacted by comorbid alcohol use, which is very common in folks that use cocaine, as well as the severity of the cocaine use disorder itself. And so this may be helpful for subpopulations, especially those that don't have significant comorbid alcohol use. So specifically, one of the trials that I looked at was from 2012, a very short trial, it was 8 weeks, and again, a small sample size of 210 people. What they found was there wasn't a statistically significant reduction over the 8 weeks, but there were some observations that the authors noted. Specifically, those in the higher treatment group did have higher odds of abstinence at the end of the trial. And they also noted that with such a short study, they wonder if there was some benefit that was delayed and not captured by this study. Another medication that has been evaluated in the past is Topiramate. So this is a GABA agonist glutamate antagonist. So it increases the cerebral levels of GABA, which helps facilitate neurotransmission, and also does some inhibition of glutamate, specifically through this AMPA blockade. And what we know with the AMPA receptor blockade is it is in the nucleus accumbens and has been shown to help prevent relapse. And so with some of the things that Acton also talked about earlier with reasons that people end up reusing again. So Topiramate has some anxiolytic properties that can help with withdrawal. So they were thinking that this might help for treatment. So one of the studies that I looked at was from 2013. Again, N of 170. There's a target dose here of 150 milligrams twice a day. The primary outcome did not show strong evidence, but when looking at some of the other things, so for looking at folks that had 3 weeks of continuous abstinence in the trial arm compared to the placebo is 20% compared to 7. So we think that it might be more impactful for those with severe cocaine withdrawal symptoms. And in one of the studies, they were looking at if it could also help reduce alcohol use, but this didn't show any reduction in cravings. And then one of the other combinations, so kind of bridging off of the Topiramate like we were just talking about, adding in a mixed amphetamine salt in an extended release formulation. So one of the groups did a trial in 2012 with 81 participants where they randomized over 12 weeks between the trial arm and the placebo. titrating up to 150 milligrams twice a day of the topiramate and 60 milligrams of the mixed amphetamine salt. What that showed was the achievement of 3 weeks of abstinence at the end of the study was higher in the treatment group at 33.3% and lower in the placebo group with a 16.7% response, which did show a significant reduction in cocaine use days with a p-value of 0.05. A few of those same authors came together again in 2019, and this was published in early 2020, where they did a replication trial with just a few more participants, still a small sample study of 127 folks. And the only difference here in terms of the doses was they did 100 milligrams of topiramate twice a day instead of 150. And again, this showed that when comparing the two groups for 3 weeks of abstinence at the end of the study, the participants that received this mix cocktail here got 14.1% compared to 0% in the placebo group, which was a p-value of 0.03. And here's just kind of a graph showing the results of that study for end of the study and then any 3 weeks with reduction. And then bupropion, which I mentioned earlier in terms of methamphetamine use, there have been a lot of trials on this looking at cocaine use disorder. So I reviewed a few of those, and there's overall low strength of evidence for bupropion over placebo for abstinence and use. But what they think, similar to methamphetamine use disorder, folks that have comorbid depression may benefit from bupropion, especially when used in conjunction with appropriate behavioral therapy like contingency management. So just kind of summarizing some of these options for cocaine use disorder. Again, no FDA approved specific drug treatments right now for cocaine use disorder. And there's been no class that has like significant strength of evidence, but some that have weak evidence may help, especially with some of the harm reduction and use. So topiramate, psychostimulants, and bupropion. And then again, kind of reiterating the importance of appropriate utilization of contingency management for treatment plans.
Okay, so last, we just kind of wanted to end this on looking ahead and what does all this information mean? I think I'll preface this with saying we are not experts, and so what we're talking about here is not necessarily hard recommendations, but more so things that we are hoping folks can be aware of in their practice so that they are more informed to talk with, counsel their patients, and then keep eyes on the horizon for future studies that will hopefully be coming out on improved treatment options for folks with stimulant use disorders. So overall, we know that there's a growing prevalence of use, particularly methamphetamine, on a national, state, local level. There's a disproportionate growth of overdoses when compared to the overall growth in use that is disproportionately impacting certain marginalized communities. When treating folks with a stimulant use disorder or a substance use disorder in general, try to develop a framework which can identify and care for those health effects. And this framework can be applied to multiple substances. When treating a stimulant use disorder, there's limited pharmacotherapeutic options right now. We need more studies with larger sample size and a larger diversity of patients enrolled. Anytime you're treating someone with a stimulant use disorder, focus on behavioral interventions, particularly having a supportive environment, harm reduction, and that contingency management that Mitchell just talked a lot about. We need to devote our resources in the communities most impacted, and ultimately addiction medicine, stimulant use in general is a rapidly growing area of treatment and research, so there should hopefully be more information coming out on the horizon. Okay, and I apologize, we went a few minutes over, but we'll take some time for questions now. I'll stop screen sharing and pull up the chat really quick. Okay. So first I'm just going to read some of these out loud. So first, Dr. Klovar is saying family physicians inherit so many people diagnosed with major thought disorders who are diagnosed while heavily using stimulants. Thoughts on teasing the issue out and weaning off atypical antipsychotics with all of their metabolic and toxic implications. Ooh, that's a good question. Again, I think it's a really, I think my approach with that would be one like nuance, like, is this someone who's engaging and care enough to where you're appropriately able to monitor some of those health effects that we can see with the antipsychotics? What is the outcome that those antipsychotics are having on the patient, right? Like particularly with that methamphetamine-induced psychologic disorder. A lot of those, psychoses can be incredibly distressing. We know on a neurologic level there are structural changes that are occurring, and so it may be that these patients truly do need these antipsychotics after even after their cessation of the use because of those structural changes. I didn't come across any studies or data that showed, like with the dilated cardiomyopathy you see with methamphetamine use, on if there's mild changes on a neurologic level, if those kind of revert back to baseline with cessation, if that psychotic disorder develops. But I don't have a great answer for that. John, what do you do to those who would say using modafinil or methylphenidate or just replacing one stimulant with another?
Yeah, I can take that one. So I think I also had concerns about that when I was looking up a bunch of different studies. And, is it beneficial to kind of replace something that also has a misuse potential? But I think here, this is mainly reducing some of the harm that's associated with some of these different substance use disorders. When looking at modafinil as well, and this is not to say that this is not problematic, especially looking at the way that opioid use disorder or opioid epidemic has been dealt with, but some of the studies in modafinil have showed less tolerance being built up, as well as kind of reuse patterns. But again, like kind of substituting one more controlled substance that requires a group that has a hard time traditionally getting into clinic with a lot of barriers to care to come into clinic to get something that's a controlled substance is very challenging. So I think, thinking about opiate use disorder and having something that is, replacing one opioid agonist with, as a treatment. So kind of being a little bit open-minded, especially when we don't have any treatment options. I don't love methylphenidate and modafinil as primary options.
And next, it looks like from Maureen, we have you seen any models for using contingency management in the primary care office, and what might that look like?
I can talk about that one briefly too. So I have not seen a lot of it. More recently, when I was rotating through the ARS clinic, working with the esteemed Dr. Schenk, we had a patient with a primary methamphetamine use disorder, and that was one of the first times I had seen it kind of discussed in terms of like real life action. So what we talked about with him would be like, if your clinic can get funding for some kind of voucher program, where when a patient comes in and provides a urine, if it is negative or whatever the goal is for that visit, reinforcing that behavior with either like a pre-purchased voucher for something, whether that's like a gift card or some kind of food ticket or movie ticket, something that they've identified as something that they associate with a reward. Or if you don't have funding and the person has support in the community, identifying somebody who can hold on to different reward incentives to be able to kind of provide to the patient when they're able to have a negative urine result or whatever they've identified as a goal for their treatment.
All right. I think that is it in the chat, and we are right at 8:30 on the dot. So thank you everyone for joining. Appreciate your guys' questions, and looking forward to future grand rounds that we get to watch.
Great. Have a good day, everyone.